In these videos, we're going to be looking at coronary artery disease and ACS, acute coronary syndrome. So, coronary artery disease by itself is obviously just the atherosclerosis, the arteriosclerosis that's progressed beyond just your peripheral circulation. It's everywhere. We've kind of said that over and over again. Once you have plaque someplace, you have plaque every place. And once we have that accumulation of plaque, it's going to make it harder for blood to flow. So in this image we see with the first slide, you can see how the plaque is built up on both sides of the vessel walls here. The red blood cells are trying to get through. Well, in addition to your red blood cells, your white blood cells, your platelets are going to be especially attracted to that area of inflammation and irritation because of that plaque. And that's also going to decrease perfusion and put you at an increased risk for formation of a clot. So we have to make sure that we understand that our bodies are going to still compensate for this. Again, just like we talked about with hypertension and the rest of these cardiac diseases, this can go asymptomatic for a really long period of time. And people will just blow it off to, indigestion or shortness of breath, just a little dizziness. And we may not be thinking about coronary artery disease and then progressing further into that acute coronary syndrome. So let's look at these disease processes. So we know that atherosclerosis is a major cause of CAD, that's coronary artery disease. You have the deposits of cholesterol and lipids within those coronary arteries. This leads to decreased oxygenation and decreased nutrition to the heart muscle itself, the myocardium. And we've said if you have it one place, you have it every place. So the clients who are at increased risk for CAD, ACS are also at increased risk for stroke, heart failure, peripheral vascular disease. When we look at this, we have to think about what we're going to do for this client to reduce all of that plaque, not just, hey, I want to focus here on the coronary arteries, because we do know that it is everywhere. So when we look at CAD/ACS, kind of initially we're going to do simple things to take care of just the coronary artery disease because it has not progressed to showing us signs and symptoms of true chest pain. But once it branches out, once we move beyond coronary artery disease to now that they're having issues, we're going to look at stable ischemic heart disease or chronic stable angina. And then these two other categories underneath ACS, which are going to be your MI and your NSTEMI, so STEMI, ST, elevated myocardial infarction, and a non-ST elevated myocardial infarction, and also unstable angina, which is all of these are accumulating into the fact that probably your client is going to end up having ischemia. Remember, that's the main cause of this chest pain, to actual injury, and that's when they have a heart attack. And in these pictures, we get a clear picture of where the coronary arteries are. We know that plaque can be anywhere along these coronary arteries. We have these situated around your heart so they can deliver blood and nutrients. And generally, this left descending artery here is the one that we probably heard referred to as the widowmaker, because it supplies most of the oxygenation to the heart. And once it's occluded, we have to do some pretty invasive things to clear that out. So just the general patho, your coronary arteries become narrow due to that plaque formation, which leads to angina or ischemia. And then that's going to lead to the infarction, and the infarction is the actual tissue death. So we want to make sure that we are addressing this as early in the first two situations as we can to make sure that we don't end up with a true myocardial infarction. And just like with everything in cardio that we've talked about, our goal is to preserve the myocardium. So we know you have modifiable and non-modifiable risk factors, but a lot of this is just because of our clients. It can be genetics, it can be due to inactivity, it can be due to the other underlying comorbidities, and we talk specifically about hypertension and heart failure and diabetes. Bad lifestyle habits, that we see NCLEX still talks about those processed foods. Foods high in fat and saturated cholesterol. And then just generally as you age, you have kind of those atherosclerotic changes. You should know, generally speaking, what we're talking about when we are talking about cholesterol or that plaque buildup. So there's a few things that we are going to evaluate. You're going to look at that overall cholesterol. You're going to look at your LDL and your HDL. You've probably heard those called your lousy and your happy. And then you're going to look at your triglycerides. Generally speaking, I can clump the first three in together because if I just remember the big picture that I'm looking at is cholesterol, it's 200. And then I want my LDL to be below that. Okay, I can remember that 130. And then that triglycerides are generally going to be around that 130 range. It kind of helps me remember where I need to start looking at, because these are going to be some of the earliest diagnostic tests we do for people who come in complaining of shortness of breath and dizziness and palpitations and all those other cardiac changes that we talk about. With our happy, I just remember my 50. If I can remember, you're perfectly happy at 50. 50 is a good number to remember to give you a reference range. So we do remember about non-modifiable and modifiable risk factors. Obviously, there's things that I can control and things that I can't. I can't control age, gender, ethnicity, family history, genetic predisposition. I can control my diet, my exercise. I can be compliant with my blood pressure medications. I can promote smoking cessation. I can lose weight. I can keep my blood sugars between 70 and 110 as much as possible. So I do see a lot of those types of NCLEX questions about modifiable and non-modifiable on those NCLEX test practice questions. There are some gender differences. We call these typical and atypical presentations of chest pain. Usually it's a little bit different in women than men. Men, we have that typical, it's chest pain, it's radiating down my left arm, it's an elephant sitting on my chest. Women will present maybe as a back pain, maybe more of as indigestion. And women who smoke risk having a heart attack 19 years earlier than non-smoking women. Women who are diabetic have it 2 to 3 times more likely to have a heart attack. Diabetes affects more women than men. And then the age-adjusted rate of heart disease for African American women is 72% higher than it is for white women. So that requires us to do a lot of pre-screening, and we do see those pre-screening questions on NCLEX. We're going to encourage lifestyle modifications, just like we would through all of the rest of our cardiac content, dietary approaches to stopping hypertension, good patient education, exercise 30 minutes a day, 5 days a week, if possible. And that's what we see with our NCLEX category, health promotion and disease prevention, right? None of that really changes. It's our goal as a nurse to be able to recognize those signs and symptoms early and do some good patient education about what we can do to decrease our risk factors. So if you do have coronary artery disease, you are always at risk for developing chronic stable angina, ischemic chest pain. Generally speaking, chronic stable angina is exactly what it sounds like. You have chest pain that occurs usually with activity, and usually when you stop and you rest, that chest pain will go away. So we are going to continue to look at that. We will have people that present to the ED or present to the hospital with a rule out MI, and it could be that they are experiencing their first onset of chronic stable angina. So we're still going to make sure that we are asking our OPQRST questions, right? So these folks will tell you, I was outside, I was exercising, working in the garden, I sat down, the pain went away. And that tells us a lot of information about whether this is acute or chronic. They'll tell us what made it worse, the quality we want to ask them about, what did it feel like, stabbing, squeezing, pressure, does it radiate down your left arm, what's the pain on a scale of 1 to 10, and I will say here that your number needs to be 0. If you have a client who comes in with chest pain and they tell you that their chest pain is 10 out of 10, and you give them a nitro tab and now it's 5 out of 10, your job is not done, right? Because we don't have chest pain at home, or we shouldn't have chest pain at home. And then we're going to ask questions about timing, because we have certain things to do as a nurse that are going to be time sensitive. So we're going to have to look at those things too when we start talking about our diagnostic tests and procedures. So here's a general breakdown of what we are going to be examining, right? So we've already said chronic stable angina. It's predictable. It's usually related to some sort of activity. It occurs with exertion. You have this area of occlusion now. It's smaller than it would have normally have been. So maybe you're only getting like 30% of that blood supply. But if I rest, that chest pain goes away because of those compensatory mechanisms, right? Your heart requires less oxygen, the less activity that it's doing. When we are diagnosed with chronic stable angina, I am always at risk if I'm not doing those things that my healthcare provider or my nurse taught me to do for developing unstable angina. And they're just going to term that a pre-infarction. The chest pain's not going away. This usually occurs at rest. It can occur at night, just like we'll talk about with peripheral arterial disease, that pain at night when you're not doing anything, that's really bad. And it's going to start occurring more frequently. Again, you're probably not doing what we're supposed to be doing as the client. And then the other one under this umbrella is going to be this Prinzmantels or variant angina. This can be due because of coronary artery spasms. So it's really going to be kind of brought more on by stress. It can still occur with activity, cold temperatures, just like we'll talk about with Raynaud's disease or Berger's disease when we look at acute arterial occlusions. You can still see some ST elevation. We looked at ST elevation when we looked at our dysrhythmias. We're going to look at it again here when we're talking about unstable and variant angina. Usually what you'll see with this type of ST elevation is that it is not consistent. So you may have a couple of QRSs that you have ST elevation, and that ST elevation goes away, and then a little time goes by, and then you have a little bit more of ST elevation in a couple of those QRS complexes. So it's irregular ST elevation because it's going to occur when those arteries are spasming. We've kind of already said that, again, because this is like everything else in cardio, it's asymptomatic for a really long time. Those compensatory mechanisms kind of kick in to fix what's going on with that lack of ischemia. So you see tachycardia, you see tachypnea, you see elevated blood pressures, all those same signs and symptoms. But most of the time, what's going to happen is that they're going to come in and we're going to get a 12 lead ECG. Now, remember, they're going to be put on telemetry. And telemetry is one view or maybe two views at most. And that's okay, but it doesn't give us that full picture of the heart. And I don't get into the different areas of the heart that you look at on a 12 lead ECG because that's not basic nursing. But you do need to understand that telemetry is different than a 12 lead. A 12 lead is a one-time picture. So I could get a 12 lead and see absolutely no ST elevation at all, and then go back to the telemonitor 5 minutes later and see ST elevation if I'm looking in the right leads. And that's why we treat chest pain as chest pain. So even though we know, a lot of our clients are presenting with chest pain and we've already got multiple 12 leads, you still need to do in that ivory tower nursing, you still need to do the right thing. So if they say they have chest pain, you're going to get another ECG. And here again, we've kind of going through the process of what to expect with ischemia. So you do need to understand this, right? So we'll look through this first one. And I see right here, I see P. I see that they do have a Q wave. Remember, a Q wave is just indicative of injury or ischemia, previous injury or ischemia, probably long term if it's chronic. Then I see the R. And then just this little piece is my S wave. It does not come back to baseline like it should. Instead, I see it elevated. That ST segment is elevated. Right? That is an ST elevated myocardial infarction. In this next one here, I see ST segment depression. So we see that S wave come all the way down here, but this ST segment is below the baseline, even though the T wave is coming back up to what we would consider normal, right? So that is ST segment depression, and you can definitely see this here. And now on this one, the T wave is doing the right thing. It's going to sit in the upright position. Remember, we said that the T wave wants to be in an upright position. The P wave wants to be in an upright position. The QRS is the only one we don't care about as far as being up or down because it's how you're looking at it. In this one, I see not only this ST segment depression, but I see this T wave inversion. Those are just fancy ways of saying that the client is either having acute or chronic ischemia or injury. If it's chronic, if it's a client like this who has a long-standing issue with hypertension, COPD, diabetes, coronary artery disease, peripheral arterial disease, this can be an expected finding, and I don't have to do anything. This, the ST segment elevation, the STEMI, is the one that is like, hey, I'm acute, I'm happening right now, you need to do something. But even though I expect this on somebody who has that long-standing history, I expect this one, that doesn't mean I'm not going to treat their chest pain by doing the right things. You still got to address chest pain. So we've said silent ischemia, it's 80% of our clients have this type of ischemia. That's going to be identified by ECG changes because the client doesn't know that they're having ischemia. They don't have typical chest pain. You have those other random cardiovascular signs and symptoms, palpitations, tachycardia, tachypnea, dizziness, syncope, whatever it may be. All right. We're going to look at our 12-lead ECG. They're going to be on continuous telemetry. They may be on supplemental oxygen. But we're also going to get troponin levels, or what NCLEX will refer to as your cardiac enzymes. Generally speaking, in the real world now, we see less of the myoglobins and the CKs and the CKMBs just because they're not cardiac specific enough. And your institutions, especially around where I'm at in the St. Louis area, are going to be your troponin I or your troponin T, and both of those have different normal values. I just like to remember it's troponin I and it's 0. If I can remember that it's 0, that I should not be having stress from my heart, that enzyme release because your heart is stressed, then I can remember that anything above 0 is bad. And again, usually now, since we should be giving you on the next gen type of questions, we should be giving you reference ranges. But if it's not one of those new next gens, you should be thinking to yourself, what is definitive for an MI? And it's going to be that ST elevation. It's going to be that troponin. Those are the big ones. And then if it's a STEMI, we're going to talk about sending them to the cardiac cath lab, because that's the other gold standard for a ST elevated myocardial infarction. So with chronic stable angina, this chronic ischemic cardiac disorder, you can have chest pain, right? It's substernal, precordial. Those are the typical signs and symptoms, right? It radiates down the shoulder or the arm. It's present at the jaw. It's described as crushing and or aching. It occurs with exercise or stress. But here is the big one, right? Again, chronic stable angina is relieved with rest and or nitroglycerin. Now, if it's the first time the client's ever having chest pain, they're going to call 911 or whatever, and they may be told to take an aspirin because they don't have access to nitroglycerin. And this is why we don't wait, because immediate care, immediate intervention of chest pain is required for all of our clients. It doesn't matter if they're at home or if they're in the hospital. We're going to take chest pain seriously. We know and have talked extensively about tachycardia and palpitations. I'm not concerned about palpitations by themselves, but usually it's a precursor that something else is going on, right? They could end up in sort of some sort of tachydysrhythmia. When we look at MIs, it's not that MI that is going to kill you. It's the hypoxia that causes the lethal dysrhythmia that actually kills the client. We could do things to clean out the coronary arteries, bypass the coronary arteries, whatever it may be. But if they end up in those lethal dysrhythmias, that is why we talked about CAB being so important versus our normal test-taking ABCs. Of course, we know that they can have tachypnea, shortness of breath, hopefully not a really low O2 because they're going to be breathing faster to maintain that oxygenation status. But that doesn't mean we're not going to put them on supplemental oxygen, because the whole problem with chest pain is it's ischemic. And ischemia means lack of oxygen. So anytime they come in, supplemental oxygen is okay. I get those of you who work in the ED, that's not what you see every day. But remember, we're prepping you for ivory tower. We're prepping you for NCLEX. So we expect supplemental oxygen to be put on a client who's having chest pain, regardless of what their SpO2 is. So the pain's usually going to last anywhere from 3 to 5 minutes. We've talked about it. Pain at rest is going to be very unusual. We've probably moved beyond chronic stable angina if you're having pain at rest. You can have these ST segment changes. You see over here in this one, it may be new, it may be transient. You have a little bit of ST depression. You see this typical presentation of referred pain. That's why we ask them OPQRST. We've talked about how the signs and symptoms in chronic stable angina can be different in women. So they may say that it's, just shortness of breath, or just pain in the abdomen, or they're just a little nauseous. It's something I ate. But then they are still seeing, that fatigue, the diaphoresis, the cold, sweaty, clammy, because it's a lack of perfusion. Variant angina, again, still occurs at rest, but it's a spasm of the coronary arteries. Usually you're going to do the same treatment regimens, with the exception that I will probably add a calcium channel blocker into the mix, because calcium channel blockers are proven effective to help with coronary artery spasms. So here again in the images, we see the normal ECG tracing. This is a couple seconds, probably 3-second tracing here. You do see P, QRST. You see that everything comes back like it should. And in the second one, this one is from a post-stress test, because a stress test is one of the things that I can do to diagnose angina, is that I do see ST segment depression. So our diagnostic tests are going to extensively include a health history, a physical exam, or laboratory studies. You're still going to look at your CBCs, your hemoglobins, your hematocrits, look to see if you have an infection. We're going to look at a 12 lead while putting the client on constant telemetry. Chest x-ray, because we want to look for evidence of cardiomyopathies. We'll talk about that when we talk about heart failure. And that's just changes in the size or the shape of your heart or the structures internally. And then for that one, we'll look at an echocardiogram. Again, we have the two types. You have the TTE or the TEE, which we've discussed already. And then an exercise stress test. Again, we put them on the treadmill to elicit this kind of response, and this is exactly what you would be looking for. It's this kind of ST segment depression. Remember, it's not just an exercise stress test. We do medication stress tests. So adenosine or dopamine are probably two common ones, but it's still the same rules that we have for that. Once we're getting this information, you don't want to cause them to go into actually having an MI. So we've got the information, and then we can stop the test if they're displaying those acute signs and symptoms. So for chronic stable angina, our goal is to promote the relief of that pain. We're going to do things or teach the client to help preserve the myocardium, right? We're going to seek immediate treatment, teach them effective coping, have the client participate in a good rehabilitation plan, and we're going to teach them on how to reduce their risk factors. So how am I going to relieve pain? You stop, rest, nitroglycerin, aspirin. You can even do nitroglycerin prophylactically. So if you know that you're going to go outside and exercise and that's what is precipitating the chest pain, you can do sublingual nitro prophylactically. The aspirin obviously is going to decrease platelet aggregation. It's going to make those platelets less sticky, so they don't want to hold on to that plaque. We're going to encourage probably the use of a statin medication, so that we know that those are to decrease that plaque overall. We want to teach them about the diet, about exercise. We want to make sure that if they do have chest pain and they are taking a nitroglycerin, that they are going to seek immediate treatment. We don't wait for the third nitro tab to call for help, because immediate treatment is the goal. So if you or someone you are with has chest, left arm, or back pain that lasts more than 5 minutes with one or more of the symptoms of an MI, call 911. Get emergency help. Do not wait. It usually takes an ambulance about 10 to 15 minutes in my area, maybe a little faster in some. But we want emergency relief, because what if the first tab didn't work? Well, if the first sublingual nitro didn't work with the aspirin, that second one and that third one probably are not going to work either. We're still going to teach them to do them every 5 minutes, right? We'll still do the nitroglycerin every 5 minutes. But while we're doing that, in that 15-minute time period, We want emergency services there to help us. Because our goal, again, is quick treatment of the heart is very important to reduce the amount of damage. That's preserving the myocardium. Aspirin, you see the commercials all the time on TV, your 81 milligrams, your baby aspirin. You may be instructed to take a higher dose aspirin, a 325, and usually when aspirin is laying around the house, it's probably in a 325 milligram tab if you're taking it for some other reason other than chest pain. But if you don't have a 325, then you can take a few 81 milligrams. It doesn't have to exactly be 325, so don't get discouraged when like, oh, all we have is baby aspirin. You take 3 of them. You're getting as close to 325 as possible. Notice they say you want to take it slowly. And we're going to do that, again, because we want to make sure that we're chewing it and not just swallowing it, right? Just like that sublingual nitroglycerin, when we're chewing the aspirin, it's getting into the mucous membranes, and it's going to be more effective. Be careful if you think that you are experiencing a stroke. And we say this because when they teach you about stroke, one of the types that you can have is hemorrhagic. If you're suffering a hemorrhagic stroke, obviously the aspirin is going to make you bleed more. So here's our exemplar. This is things that we could teach them. Just basic understanding of you come to the hospital with chest pain. So ECG, we're going to look at that. It's going to either have ST elevation or no ST elevation. You can have ST depression. You can have T wave inversion. Again, I just want you to remember that these things are fancy ways of saying ischemia. We're going to look at our troponins. We could probably, if it's chronic, expect a stress test, either chemical or exercise. But from an NCLEX perspective, what is the priority action? What is the immediate thing? We're going to look at MONA, and we're going to add a lot more to MONA as we go. It'll be MONA B, STARS, all this other things to differentiate between, this chronic stable angina from the true MI. But we're going to use morphine because morphine is going to decrease your anxiety. You're going to be pretty anxious if you're having chest pain. It also decreases preload and afterload. So we talked about that. That's going to make your heart work less hard. So that's a good thing. We're going to give supplemental oxygen because the whole issue with chest pain is ischemia. We're going to give nitroglycerin because nitroglycerin is going to promote vasodilation of your coronary arteries. And then we're going to give aspirin, if it hasn't already been done, to prevent that platelet aggregation. And that is our coronary artery disease / chronic stable angina / variant angina. Remember, big picture, it's a lot of teaching. It's a lot of making sure that their patients are compliant with diet, exercise, medications, controlling comorbidities.